let's just be honest. We do 4 years of medical school where we're learning general medicine, and then we do our residency training where we're learning a bit of general medicine and then our specialty as well. So it does make us more well-rounded. We have a deeper understanding of physiology and pathophysiology, and there's things that we know that necessarily a CRNA is not going to know, necessarily a CAA is not going to know, and that's why I believe in physician-led care.
As someone who does locums, like I've traveled to other places, and then I did my training, my residency down south. I did my fellowship in the Northeast. I mean, there's definitely differences
Mhm.
between the way larger academic centers and smaller centers will treat you. When I go to the smaller hospital in Pennsylvania, they're just so kind.
Mhm.
Um, and like they have ancillary staff, which is
Yep.
unheard of in New York City hospitals. So yeah, no, you have to find the right fit because it might not be the career, it might be the work environment, honestly.
Exactly. Mhm.
And I know you briefly touched on CRNAs, and we've talked about this through our social media interaction before. But can you tell us a little bit about how you feel on the evolving roles of APPs and not just CRNAs, but I know CAAs also, I
Mhm.
think, technically count as APPs in terms of anesthesia. How do you think we can balance the collaboration, which I think is needed, but
Right.
also with the training and the responsibility?
Well, I'm a physician who believes in physician-led care. That being said, I have been in practices. I have actually locumed at a small, what they call the CAH hospital. What is it? What is? I can't even remember what CAH stands for. But they're usually 25-bed hospitals out in the middle of nowhere that serve very small communities. And in places like that, they usually just have CRNAs running the anesthesia, and they don't have physicians. But I was there a couple of years ago trying to get my case numbers, and I guess they were so desperate that they allowed us to go in. So there are places like that where CRNAs predominate. Those are a small fraction of the majority of anesthesia care in the United States. For me personally, working in a place like that full time, I would be bored because again, I'm an intensivist. I like the sicker, more challenging cases. So I can certainly see how CRNAs working in those practices are filling a need, filling a void. And as long as the cases are selected appropriately and the ones that are too sick are turfed to the bigger centers, and that's fine because we don't have enough anesthesiologists, we don't have enough physicians, as you know, in general in this country per 100,000 population like they do in other countries. So there is a staffing shortage, and yes, NPP, I call them NPPs, non-physician providers, are needed, but I feel like that the collaboration with physician is very important. I believe in physician-led care. I can see how in much smaller towns and stuff that they may have a difficult time recruiting physicians. That in that situation it would be on them. But I feel like those NPPs need to realize when to refer to a physician, and I hope that they do. But you don't really know. It's kind of like that thing where we say we don't really know what we don't know, right? So there are probably people out there who may not be getting referred appropriately. But let's just hope that that's not the majority of patients, and I just don't think necessarily that the majority of NPPs are in it for their ego. They're really in it to help people just like we are. And they want the best for their patients. That being said, the leadership organizations can throw a lot of difficulty, a lot of shade when it comes to basically saying that they train the exact same as we train. They know that they do the exact same things as we do. They have the exact same um um what is it? What am I trying to say? I can't even think what I'm trying to say at this moment. But anyway, what they try to say is basically they're trying to equate their training to physician training. And that's just simply untrue. And that to me is a problem because lay people may not know that their training is different than our training. And physicians, we're taught as physicians to study general medicine first before we specialize into whatever specialty we're going to. Whereas with CRNAs, they specialize already from the beginning. So there is that gap in knowledge. And it's hard for the militant CRNAs to see that, but the ones who've actually done CRNA and gone back to MD or DO school will tell you There was a lot of things I didn't realize that I didn't know. And I've met two of them. One was my program director from my medical school. She used to be a CRNA, and one was a former chair of the ASA who was the chairman of the OU Department of Anesthesia. Both of them were CRNAs. They went back to school and they became physicians, and they both were like, there is this gap in knowledge. And let's just be honest, we do 4 years of medical school where we're learning general medicine, and then we do our residency training where we're learning a bit of general medicine and then our specialty as well. So it does make us more well-rounded. We have a deeper understanding of physiology and pathophysiology, and there's things that we know that necessarily a CRNA is not going to know, necessarily a CAA is not going to know, and that's why I believe in physician-led care. I think it's best, and for us in anesthesia, the research has shown that ACT model, which is the anesthesia care team model, which is where the anesthesiologist is supervising multiple CRNAs or CAAs or residents, is the one that has the best outcomes, and then followed by physician-led care, and then followed by CRNA-led care. I mean, there's research to show that, and I do believe that just most CRNAs want to work with physicians, most CIAs as well. Obviously, CIAs have no choice, but I do believe that most CRNAs want to work with physicians and they want to provide the best care for their patients. And I have been in practices where the CRNAs are amazing. I left one of those practices last year, early this year, I should say. And they're competent, they're friendly, they don't give you, much pushback, and it's a collaborative, happy environment. But I've also seen the opposite where, the CRNAs and the physicians are antagonistic and they just make for a toxic work environment. And in that situation, I got in, I got my numbers, and I got out because I just did not want any part of that. I don't need that. I don't want to add any mental stress to a job that's already stressful enough. You know what I mean? So they're out there. The practices are out there. I do believe that we need to collaborate with them. I do believe they need to collaborate. They need to be willing to collaborate with us and not look at us as the bad guys who are just trying to take their money so that we can sign off on 10% of their charts and not help them. And I also do believe that there are physicians who do take advantage of them in order to make a bunch of money, and we got to take accountability for that as well. And I do on my channel, I call those physicians out myself. So it's like my channel is like I talk about everybody, including myself. So we have to take responsibility and realize that we are part of the problem, and we have also helped create this environment now where we have like this overproliferation of NPPs, and it's become a situation where now it's more like it's becoming antagonistic where it shouldn't be. So that's what I think. I love my CRNAs who are easy to work with, who are competent, who don't have a big ego. And the ones who come to work with a big ego and are difficult to work with, I want no part of it. Nothing. Go do your thing, be independent, leave me alone.
Couldn't agree more. Yeah, the big ego can be very, very dangerous actually in patient care. Um, so, coming from an RN background, what do you think about RN leadership? That unfortunately is there to tell physicians what to do and what not to do.
Hmm, that's a tough one. Here's the thing. I really I really believe that the RNs are in this space, the RNs are more intelligent than physicians because what they're doing is they're taking over a lot of leadership positions. They're pushing themselves and they're squeezing themselves into spaces that traditionally were held by physicians. Okay. They're taking that power. Okay. They're banding together and they're taking that power. And I think we also need to be cognizant as physicians to see that there's nothing wrong with being collaborative and welcoming our colleagues in the nursing side, but we need to keep our eyes open because eventually it's going to be a situation, honestly, where it's going to be upside down. If you have nurses who are in charge of the American Academy of Cardiology, who've been past presidents, I think 2000, early 2000s, they first saw their nurse who was who was the president of that, the Cardiology Association there. And then we have the NRMP, which is the physician resident match, that there is a PhD RN who is the CEO, I believe, or the president. I really just don't understand how that is happening. I have a problem with that because there's no way that they're going to let us go to their organizations and be leaders in their organizations. But they're smart enough to where they can come to our organization and, you know, find themselves and allowed, well, basically, are welcomed by us to be leaders in our own profession. And I feel like in that situation, there needs to be a line. It's like we can collaborate, but we need to realize that these are physician organizations, these are nursing organizations, and they need to be kept separate. Because if we just keep allowing this, to be quite honest, if we keep allowing this, it's going to be a situation eventually where the nurses are now in charge of all these medical organizations. And that's going to be a problem because now it's really going to be a situation of a power play. And the physicians are going to power. We have to keep our eyes open. We really need to do that. And I think we're too, maybe it's the altruism. Maybe that we're just looking at it thinking, oh, that's not a big deal. We should welcome them. I'm not saying that they don't have a place. Obviously, as a nurse, they're human beings, they're healthcare workers, they have a place. But I do believe physician organizations should remain physician. And I do believe that nursing organizations should remain nursing. And this interchangeability, well, it's not interchangeability. These places where they're putting themselves in admin role that were traditionally by physicians or in actual medical organizations, I believe that's going to lead to problems later on. But hopefully, I'll be retired by then.
I think you made many, many great points that actually Shala and I have discussed before. We recorded some more episodes on APPs and we kind of touched on some of this, but one of the things that you just mentioned that I don't think we have discussed is the nurses are the head of a few physician organizations. You're absolutely right. The American Academy of Cardiology being one, which one of my friends, her father's a cardiologist, like an old school cardiologist. When he heard that, he almost fell off his chair. He's like, "What?"
Right.
Like it's shocking. It really is.
Yeah.
And again, it has nothing to do with intelligence. That's the thing,
Right.
right? Like they feel like we're attacking their intelligence. It has nothing to do with that. It purely has to do with the amount of training that you've had and the level of expertise that you have in a field.
Yep.
Again, you can be the smartest person in the world, but if you haven't put in the amount of hours that we have to hone our skill, you're just lacking in that skill. It's very objective.
Right. Right. I don't know. We need to keep our eyes open. Keep our eyes and our ears
Yeah.
open because honestly, I you know, I see the end result not being great. It really isn't. And I think a lot of it comes from their years and years, to be honest, their years and years of basically like being treated like crap by physicians. And to them now they're getting to the point where they're like, we're going to be empowered and it's going to be our turn to take charge so we don't have to be treated like crap and we can be in charge of these physicians. I can see that. I can see that. But at the end of the day, we need to keep our organizations ours, and just like they need to keep, like, if I went right now and I was like, you know what, I think I want to run for the president of the ANA, there's absolutely no way they would let me. Any nursing organization, they would not let you in there. So why are physicians allowing it for us? Like, why are we allowing it? Why is there a nurse who's in charge of the NRMP? I like,
Who knows nothing about
who knows
residency or the
nothing
match
about our
process.
training, who's obviously has to learn all these things about the match process. It's like, how is that allowed? How does that make any sense? You mean to tell me there was not a physician to take on this role? It just does not make sense. So
Yeah, and I
that's
don't
my
know the solution for it either because you're right. We have to keep our eye on it. But honestly, like you and I are on social media, and then there's also these like Reddit pages, Facebook pages of physicians, and I think generally we all have the same complaints, right? And we
right.
all have the same attitude. But what do you think is lacking, Susan, that we can't get from point A to point B in terms of trying to put all our efforts in together and moving forward? Because like you said, you can't even blame the nurses or the APPs. They're
Right.
doing an amazing job unionizing and
Yep.
propelling their profession forward, and we're just kind of like do do do, in the back
Exactly.
burner.
We are
Exactly.
working like 60 hours per week and not having time to do anything else, not getting overtime, you know,
That too. That too.
compensation, and uh, and paying back our loans, our $400,000 loans. So who has time to go fight?
And I think I also touched on that on like one of my videos. I think a lot of physicians, when you look at unions, right? Traditionally, unions came from who? The working class, right? Because literally what I just touched on a little bit. They were used and they were abused by the capitalists, but their employers, and they wanted to have rights, obviously, right? So typically, you're talking blue collar versus white collar. Traditionally, medicine has been a white collar job. It's changing, but it's traditionally been, right? So the people who went into medicine typically came from, upper middle class kind of backgrounds where they didn't have to unionize to fight because, well, they had all that privilege of not being abused, of not being underpaid, of not being mistreated. So it's still traditionally, when you look at it, traditionally still about 50% of people who go into medicine still come from the upper middle class. So I think their outlook is going to be different than when you look at people who traditionally go into nursing. Their outlook is going to be more like, well, I've my parents worked hard and they made themselves a good life. I've worked hard, I deserve to be here. I'm going to make myself a good life. I'm going to do what I need to do. And it's basically like this white picket fence that surrounds their life, metaphorically and physically. And all these other things, well, they're affecting other people. Let me focus on me because life has been good to me and it continues to be good to me. Kind of that situation when you're part of the masses and you're part of the ones who are being mistreated, the rising up and fighting against the power comes a lot more naturally. You see what I'm trying to say? That's really what I feel.
Yeah.
That's like one of the things. I think just it's a class situation that I think prevents physicians from coming together as much as like the nurses.
Yep, I think that's also. I think part of it is also public perception, and I think that comes from what you just said. We're not working class, right? So usually
Right.
when people unionize, it's the working class to who are being mistreated and abused and underpaid, and they need to come together to collectively advocate for themselves. Well, physicians have historically been white collar, so when we try to say anything, and also I've seen this on social media about how we're being mistreated or abused, I
Right.
think
Yep.
there's no general support from the public because they're like, oh, F out of here. You guys are so rich. You're making so much
Right.
money.
Exactly.
And they're not wrong. We are paid well. But in the grand scheme of things, if you keep looking at what is being demanded of us in
Yep.
terms of the time, the sacrifices, the loans, and how much money people are making off of our work
Yep.
that we're not seeing, I think that's a big problem, but I think part of it is also kind of getting the public on your side, which I think is going to
That's
be
very
difficult.
true.
A lot of people are doing it now on social media, especially residents. I think you and I see those TikToks from residents who talk about how
Right.
poorly they're paid. And then the comments are all people surprised, like, wow, you're making that much and you're working that much. It's like I don't
Right.
think people knew before the current like social media generation.
All that. So it's multifactorial. And yeah, trying to get people to understand that yes, we can be mistreated and abused in a system where they require more and more and they stretch us thinner and thinner, while we're making low to six, mid six figures. To them it's like, yeah, who cares, you're making all that money, the rest of us are being abused at a fraction of the price. So yeah, like you said, nobody cares. And we are going to be villainized for complaining and for wanting to stand up for our rights because we make good money. So that's actually a really good point as well.
But I think the bottom line, and I think this is what we need to emphasize, is that this is affecting patient care.
Yep.
It's leading to bad outcomes.
Yes.
And patient care overall is very poor in the United States, especially if you compare it to some of the other countries who are, let's say, about like around the same gross population and gross
Yes.
economic status as us. We don't do well in healthcare. There's a lot of inequity in healthcare, and
Yes,
it's
there
going
is.
to get worse. I mean, the rich are
Oh yeah.
going to get good healthcare, whereas the general population is going to suffer. They're going to see APPs, which no shade on APPs, but we just discussed that there is a difference in expertise. So I think we really need to emphasize that this isn't like oh, I'm not getting paid enough issue. This is okay. So what's going to happen to the future of healthcare issue?
Exactly. Exactly. Because as I have touched on too, one of the things that really worries me is the quality of NP education. There's a lot of NPs who hate me on social media, but there's a lot of NPs who follow me and love me because I keep things honest. The one thing about me is I try to keep things as honest as possible. But what we have seen over the past 20 years, if you look at the number of NPs, they have quadrupled in the past 20 years. And it all began I think it began in like the mid early 2000s. And then when Obamacare came, he allotted a lot of money because of the shortage of healthcare. He allotted a lot of money to, expand nursing programs, to expand mid-level programs. I guess people don't want to use that word, but you know what I mean. So a lot of this funding came from Obamacare, and a lot of these schools just said, screw quality, we want money, because there was money coming from the government. And so a lot of these schools started popping up left and right, taking all kind of nurses straight through who never had any kind of experience, and the quality has gone down the tubes. Let's be honest. One of my more popular videos is one where I was talking about that. It's like the quality has gone down. There's still some very good NPs out there, but you find that a lot of those NPs have had years of experience. I don't agree with NPs going to school who've had less than like 5-7 years of experience. And then also NPs who go to school, and let's just say they were concentrated in the ER, they worked in the ER for like 7 years and decided to go back, and now they want to be a psych nurse because psych nurse pays the second highest as far as the APRNs after CRNA. And they're like, well, we get plenty of psych patients in the ED. That's not the same as managing somebody who's going through a bipolar crisis for 2 weeks in an inpatient setting, or somebody who's having a psychotic break and you're trying to differentiate, is this a medical issue, is this a psych issue? That is not the same thing. You see them acutely for a few hours. That does not make you experienced enough to go back and get your PMHNP. So I feel like the quality, it's not like I feel like, we all know the quality has gone down. A lot of the nurses are complaining that they don't get taught anything. They have to self-learn. So what's the point of paying all this tuition if they're just going to give you study materials to go self-learn, and they're having to pay for their clinicals, which they're paying a bunch of tuition, and then the schools are keeping it, not finding them proper preceptors. There's rampant cheating. So the quality has gone down, and we see it. We complain about it. And then of course we're called elitist, and we're gatekeeping, and we want to be the only ones who diagnose and treat, and all these negative things. At the end of the day, like you said, it's a patient safety situation. There's a lot of poor quality out there now, and we need to talk about it, and we need to let the public be aware. And yes, there is a lot of good ones out there, but how are you going to decipher who are the good ones from the bad ones when you are a patient?
Yeah, a lot of good points. Do you feel like the institutions even care about the
No.
quality
No,
genuinely?
they
Like,
care
I
about
don't
the
think
money.
so.
They care
Yeah.
about the money that they're making from these very naive nurses who see social media and see a great lifestyle that the NPs are having, and they see the good money, and then they're not, having to flip patients over and hurt their back and clean patients. They're not providers. I think a lot of them are sold a lie, and they're told you don't have to have this experience with teaching, and they go to these schools and then they're not taught what they're supposed to, but they're like, well, I'm still going to make the best of it. And they come out, they're NPs at 23, 24, 25, 26, don't have the proper experience, don't know what they're doing, and they're probably too scared to say something about it, or they're given a job that they're told is going to go one way, but then when they actually arrive there, it goes a completely different way, where their responsibility is a lot more than they thought they were going to get, and then they're kind of stuck. There's a lot of NPs who've gone back to bedside because they're like, there's no way I felt unsafe. I felt like I didn't know what I was doing. I felt like I was going to harm somebody because it just was too much. So no, those schools don't care. The schools that, mushroomed up just to make a bunch of money, the online schools, the degree mills, they don't care. They just want money.
Yeah, I mean, I was going to say, even the employers who employ, APPs, they don't care either. I mean, it's
Nope.
just performatively, they say it's like a theater. Even though some physician-led organization, they have APPs and they make the providers see 15 to 20 patients a day, the physicians, some just happy with mediocre work,
Yep.
until a lawsuit happens. They don't care. They say they care, but in reality, their actions actually show that they don't care about the quality of patient care.
Exactly.
It really, we all are being abused by the system. I mean, there's
Yep.
no reason why a freshly graduated NP should be able to practice independently, and
That
they
is so
can. They
scary.
can in like over 25 states, I think.
Yep.
Um, it's wow. It's it's like us
Scary.
not even like in second year of medical school going out there and practicing independently. I can't even imagine. I mean, it's not good for the MP either. It really opens them up to a lot of liability. So I don't think this is benefiting anyone. So just to shift gears a little bit, I think what I kind of want to close out on is, what does success look like for you now compared to when you were in training? Do you still view the same milestones as, okay, now I've made this much money, I've done XYZ, now I'm successful, versus I can take vacations, I have flexibility. Now I'm successful. How has that transformed for you?
I think it's the later one. um, I think, I'm now what, mid-career. I'm 13 years out from residency and like 7 years out from my fellowship. So I guess I'm, what you consider mid-career at this point. And I feel successful. There's some people out there who probably who have made fun of me for being a locums physician. It's like you can't even find well, it's not like I can't find a permanent home. I just like my flexibility. And to me, success is having that balance. I go to work, I take care of my patient to the best of my ability, take care of them like they were my family member. I go home and I sleep and I'm comfortable knowing that I did the best I could for my patients at work, that I'm competent. But I also make time for myself to where it's not this grind where I'm constantly at work. I'm begging to have my time off so I can decompress myself, have some me time, spend some time with my family. And I feel like a lot of physicians don't have that. A lot of physicians are stuck in this grind where it's like work, work, work. Yeah, you're making good money potentially, but you are working all the time. You're exhausted. You may be working in a toxic environment. Are you really happy just because you're making, five, 600, $700,000, but you're working 60 hours a week and you barely have any time to take care of yourself and your health, and you're eating poorly, you're not exercising, you're not seeing your family, you're being snappy with everybody because you're exhausted? Is that really a life of success? To me, it's not. To me, it's not. So for me, success is to have that flexibility, to have that downtime, to have a period where I'm separate from my profession, where my profession is not all consuming of my life, and I have my chill moments. So I feel successful. I feel very successful as a locums physician, where I get to make my own schedule. I'm on my stretch right now. Funny that I'm probably on my fifth week of working straight. My family's like, "When are you gonna take off?" Because they were used to me taking off like every 2 weeks. I got 4 more weeks, and I'm like, "Oh my god, I can't wait till I can take off." So for me, it's really just having that flexibility to take off when I want to take off to decompress. Um, but the past few weeks that I've been working in good environments where I don't really feel stressed to go to work, so I can go to work on these longer stretches and still be happy and not be, angry and upset that I'm working all the time and stressed at work?
Right. Have you had mentors who helped you with choosing this path, or did you just carve your path mostly alone?
I don't know if I had mentors per se. I always wanted to be an OB-GYN. My personal statement for medical school was I want to be a women's health physician. I want to take care of women. Then when I got to medical school and did my third year in OB, I realized how mean those doctors were, how sleep deprived they were. They were working all the time. I was like, want no part of this. So then I changed to psychiatry because, like I said, I have a mother who has some mental health issues, and so that spoke dearly to me. And I did so many electives in psychiatry, and then I thought to myself, before I graduate medical school, I want to work in the ICU because that's something I always wanted to do as a nurse, and I never got a chance to do because I was always in school and I didn't have time to do the nurse residency. So I did an ICU elective that was run by anesthesia. Fell in love with it. I was like, this is so cool. But at the same time, I was very unsure of myself because it was very challenging. Those patients were really sick. There was a few deaths happening here and there. And I met the guy in medical school who was in charge of the fellowship, the ICU anesthesia fellowship. He was, I guess, kind of my first mentor, even though he kind of started off kind of making fun of me that I wanted to be a shrink, a psychiatrist. Um, he really was like, "No, come on, come over here. Look at the cool stuff that we do. Look at the sick patients that we take care of." And so he kind of challenged me, put that seed in my head to where I'm like, you know what? I can do this too as well. Psychiatry has its own challenges, but this is also a different type of challenge, and I can do this. So that was what I would get. That's what I would say my first mentor was. And then in residency, when I started having a lot of my issues with my remediation and my probation, I had this pediatric anesthesiologist who used to be a pediatrician, went back for anesthesia and became a pediatric anesthesiologist. And he really was the one who helped me through all my struggles. He knew what was happening to me was unfair, but he also did let me know that I needed to take more responsibility, which I did. But then he would lay out plans for me. We would get in his office and we would discuss things. And he really just motivated me and put the positivity in my brain that I needed in order for me to keep moving forward, because I'll be in his office just almost in tears, just telling him of all the drama that's happening on the adult side of anesthesia. So those were the two mentors that I had. But I would say the one in residency was more of a mentor for me because I was with him for a good year, versus the one, who I was with like for a month when I was in resident. I'm sorry, in medical school. And after that point, my partners, when I was out west in that group that I ended up leaving that was doing a lot of spine and brain, those partners were mentors to me. And in fact, I still keep in touch with one of them. He's like 72 now, and I believe he's retiring soon. So he was a mentor for me in private practice. And then my first group, the partners were mentors for me. So I feel like in every group that I've joined, I've had some mentors in the partners or my colleagues. But in residency, it was my attending, the pediatric anesthesiologist.
How do you protect your joy and peace while working in the system? Just as advice for young residents or young trainees who feel like the system kind of just is eroding everything that they have, which it tends to do.
So for residents and trainees, the one thing I'm going to say is they can't stop the clock. They tried to extend my residency for 3 months, and of course told me all these negative things, that I would never pass my boards, I would never be an anesthesia, all these things. All that negative talk, that's their problem. Focus on you moving forward every day, reading, knowing your patients, knowing your pathophysiology, coming to work on time, being prepared and doing the best of your abilities, and knowing that these people cannot stop the clock. So it's just difficult as a resident or as a medical student because you don't really have much power, much rights. And so what I tell people is you have to kind of ignore the background noise. You have to do your best to ignore that negativity and focus on the future, because I promise you it does get better. Once you're done with your training, once you have that, certificate from residency and fellowship, and then once you sit for your boards and you pass your boards and you have that, it is so empowering. And I'm telling you, it's like night and day how I was treated. And this is not just my experience. This is a lot of people's experience. It's like now, it's like you are having to prove yourself all along that you're good enough to be in this boys club, per se, white boys club. Now you're here. Now you've proven yourself. Now we can welcome you. It's terrible, but it's kind of the truth. So in residency and medical school, I just say keep your head down, keep your head in the books, ignore the negativity. If you have a loud, crazy personality like me, you kind of got to bring that back down, because it's kind of a performative sport that you got to do for, a period of 3 to 7 years, and they can't stop the clock. And eventually you're going to get there, and it's going to be like night and day. And eventually you're going to be empowered, and you're going to be where it is that you've worked so hard and sacrificed so much for.
Okay, thank you so much, Susan. Where can people find you if you want people to find
You mean like
you
online?
on social
I'm
media or
yeah,
YouTube?
I'm
Yeah,
actually
social
still
media or
pretty
YouTube.
lazy on YouTube, but I am going to continue to make my YouTube videos, even though it's like one every 2 or 3 months. You can find me on YouTube. I think Susan Flyer on YouTube. You can find me on, of course, TikTok, Susan Flyer. You can find me on IG. I don't really do much posting on IG, but I'm Susie Q International on IG. And then, of course, if people want to send me an email, it's susanflyer4@gmail.com. So that's where I'm at, mostly on TikTok.
Thank you so much, Susan. And thanks for the audience. Thanks for tuning in to Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, rate this podcast, and share it with someone who needs to hear this. Stay strong, stay empowered, and we'll see you next time. Thank you.